This is a short discussion on spontaneous intracranial bleeds. By spontaneous, we mean that the bleed was not provoked by trauma. So, intracranial bleeds, which occur without antecedent trauma, include intracerebral hematomas. The commonest of these are the hypertensive intracerebral hematomas. There are also hematomas which are secondary to aneurysms and vascular malformations and also to vascular tumors. Cerebellar hematomas may be hypertensive or they may be because of vascular malformations. We have included chronic subdural hematomas in this group because a history of trauma is often not forthcoming because the injury might have been trivial and unnoticed. Spontaneous intracerebral hematomas may be hypertensive. In fact, these are the commonest. And very often these hypertensives are also taking antiplatelet drugs, which makes the situation a little worse. Hypertension may be under treatment, and there are patients who have been detected hypertensive and who are not taking regular treatment. Small vessel disease is associated with hypertension, and cerebral amyloid angiopathy is considered to be a major cause. Secondary intracerebral hematomas may occur because of vascular malformations. They may occur because of cerebral venous thrombosis. They may be hemorrhagic transformations of stroke. Primary or metastatic tumors might produce ICH, moya disease, cerebral vasculitis, and mycotic aneurysms are other causes. There is a group of patients who are on anticoagulants who are prone to intracerebral hematomas. Anticoagulant use may be for cardiac indications, atrial fibrillation, or after valve replacements. Renal patients, especially those on dialysis, may also present often with impaired sensorium, and a CT reveals an intracerebral hematoma. Primary major risk factors are hypertension, oral anticoagulants, and amyloid angiopathy. BP is a very significant factor, and a systolic BP more than 160 usually results in larger bleeds. It can result in expansion of bleeds which have already occurred. How do those patients present? They often present with headache associated with sudden neurological deficits. In some patients, headache may be absent, and the patient might just present with a unilateral weakness or a difficulty in speech, mimicking a stroke. Patients may have decreased Glasgow Coma scores, usually associated with increased intracranial pressure. The blood pressure at presentation is usually high. Clinical evaluation shows low GCS in patients who have increased intracranial pressure and those in whom the location of the bleed is close to the core brain. Radiology, a CT scan will show the size of bleed, a location of bleed, and also if there is intraventricular extension. Both larger bleeds and the presence of intraventricular extension are reasonable poor prognostic features. Blood extending all the way up to the fourth ventricle is associated with a higher morbidity and mortality. Very often these patients undergo an MRI as the patients are suspected to have an ischemic stroke and the hematoma is revealed. Patients of intracerebral hematoma may require intubation and elective ventilation if the Glasgow Coma score is 8 or less than 8. At the time of intubation, usually a Riles tube is passed This is not only for gastric decompression, but also it facilitates the use of oral antihypertensive drugs, which are required. BP control, as we said earlier, is vital. Systolic BP is more important for prevention of bleeds than mean arterial pressure, which is more important for cerebral perfusion. So both could be considered. Keep the systolic BP less than 160. Labetalol or NTG may be started initially. Oral antihypertensives are started as soon as possible, if necessary, through the Riles tube. Anti-edema measures usually involve mannitol. Correction of hyponatremia with 3% saline is often required, and 3% saline can be administered till the sodium level is around 145. Role of steroids is limited. However, if the perihematoma edema is significant, steroids may be administered with some benefit. Anti-epileptics are required even if there is no overt seizure, because the risk of occult seizure activity which impairs neurological function is in the range of 30 to 50%. Riles tube feeds and oral feeds can wait at least for 48 hours and often for up to 72 hours. What are the indications for surgery in intracerebral hematomas? There was a multinational randomized prospective study, the STITCH trial. However, the indication for surgery is ultimately the clinical profile. Size of hematoma was studied in a STITCH trial. Location of hematoma is also important, and more easily accessible hematoma is easier to evacuate and safer to evacuate, and also it provides benefit to the patient. Small hematomas less than 3 centimeters are often left alone. Very large hematomas, where the patient has got bilaterally dilated pupils and herniation, may not benefit from surgical evacuation. Principles: that are open surgery is often performed. An appropriate craniectomy is done. You don't need to do a decompressive craniectomy often in these cases. An appropriate corticectomy, which provides an adequate trajectory for tackling the whole length and depth of the hematoma, is chosen. We do not usually replace the bone flap after evacuation of an intracerebral hematoma, as some amount of vein edema occurs. Endoscopic evacuations have been described. Probably these are not good options when the intracranial pressure is high because of the accompanying cerebral edema. Physiotherapy. Passive physiotherapy is started from day one. Active mobilization usually waits till the edema subsides and hematoma increase is excluded. That is, serial CTs do not show increase in the hematoma size. Cerebellar bleeds often require surgery. A digital subtraction angiography may be required to exclude vascular malformations, aneurysms, or highly vascular tumors. Indications for surgery include the size of the hematoma. 3 centimeters is an often taken cutoff. Location of hematoma. A more medially located hematoma may warrant evacuation. Hydrocephalus, which usually is associated with obliteration of the fourth ventricle seen on a CT scan. A unilateral craniectomy may suffice in a lateral cerebellar hematoma. Wide posterior fossa decompression is often done. Chronic subdural hematomas are a different entity, often provoked by trivial trauma. Bleeding occurs into the subdural space. Osmotic expansion occurs. Recurrent repeated small bleeds add to the osmotic pressure, and the hematoma keeps expanding till it presents with a neurological deficit. Indication for surgery is mass effect and a midline shift. The technique is usually through two burr holes, irrigation, evacuation of the hematoma. Try to prevent pneumocephalus from occurring by logical irrigation of saline and by filling up the cavity with saline before closure. Endovascular procedures have no or limited role in primary subdural hematomas, chronic subdural hematomas. They may have a limited role in recurrences by decreasing the perfusion, by decreasing the blood flow through the middle meningeal artery. Role of tranexamic acid? Yes, tranexamic acid may help in resolution of some early subdurals, and it may prevent reaccumulation of blood. So in an overview, let us see hypertensive ICHs may require intubation and ventilation if the GCS is poor. Maintaining the systolic BP less than 160 millimeters of mercury is vital. DSA may be indicated if there is any suggestion of an aneurysm rupture or an arteriovenous malformation. Surgery is required for the relief of intracranial pressure. Removal of a clot, especially if closer and accessible, is desirable if it is more than 3 centimeters and if the removal of the clot is likely to be associated with limited morbidity. Cerebral hematomas can be approached by unilateral or bilateral approaches, and the principle is to decompress the brainstem and to relieve the pressure on the fourth ventricle. Chronic subdural hematomas are evacuated by two burr holes in the frontal and parietal region usually, because that is the location of a chronic subdural hematoma. Anesthesia, general or local sedation can be used, and the role of endovascular procedures is very limited.